So there are two programs that are either in late stage or going to late stage development with antibodies, BAN2401 and also gantenerumab. And in both of those cases at this point, from earlier studies, there are signals that there may be clinical benefit and at least suggestion or signals that there may be amyloid removal. But again, given the complexity of this disease, these programs need to really go and read out for us to be able to say something. Each of these antibodies work in a different profile. So where some of them work much more on the plaques or the fibrils, some of them will work more on the protofibrils and fibrils, and some will work across the spectrum. So given that and that the criteria are different, I think there's still hope, even though that's been sort of moderated with the recent failures. The other approaches I mentioned are the BACE inhibitors that are still ongoing for amyloid. But I think while the enthusiasm for amyloid-related treatments being a bit mitigated in the dementia stages of Alzheimer's disease, what's still, I think, a big area of exploration are, tau-related approaches, including antibodies or aggregation agents. And as I mentioned, there's also a fair bit of work now on, targeting specific inflammation, vascular brain injury, and also targeting the other components of proteins that may cause dementia syndrome. It's not all related to Alzheimer's disease. And aging factors are going to be important, affecting mitochondria are going to be important. So, there's still a vibrant group of drugs that are in development, and we still need to, have the mobilization between neurologists, our patients, clinicians, industry, the government, and biopharma, because this is all our problem. Without actually doing these studies, we won't really know the answers. Beyond that, there are symptomatic approaches. There are individuals in moderate to severe stages of Alzheimer's disease where a lot of the treatments are not, the new treatments are not being tested. And we really do need treatments to add on to our current treatments for those. Often with those individuals, I think what's becoming more clear is that the approaches that are amyloid related aren't going to be working at that stage. And we still need to find out other approaches, including with neurochemicals, to help them with symptoms.
The BAN2401 trial involves an antibody that is thought to get at the protofibrils in the Alzheimer's amyloid cascade. So as you go from soluble to insoluble amyloid in the brain, protofibrils are kind of intermediate along that line. So this antibody is designed to take that out of the processing step. In a recent trial of BAN2401, the individuals who received the highest dose of that antibody actually had amyloid removed from the brain, and there was a suggestion of clinical stabilization or perhaps improvement. And this was a suggestion now that this might be an effective treatment. This company is going to be launching a new study using this agent to see if we can in fact remove the amyloid from the brain and have a clinical outcome that is beneficial. Well, the use of BAN2401 now is somewhat controversial because all of the other trials aimed at symptomatic people, that is people with mild cognitive impairment or people with mild dementia due to Alzheimer's disease, have largely failed. Well, BAN2401 is looking at that same population of people with mild impairment, and some question whether in fact it's reasonable to go forward. However, others indicate that this antibody may be a bit more specific, again, for the protofibrils in the amyloid cascade, and therefore may be beneficial and is presumably safe. Now, all of these antibodies run the risk of producing a condition called ARIA, which is a microhemorrhages or a little bit of edema in the brain, thought to be due to a breakdown of the blood-brain barrier and substances seeping into the brain as a function of the antibody actually removing amyloid, perhaps from the blood vessel wall. So this ARIA is in fact being followed very carefully. It can be monitored by MRI, and you can adjust the protocol and all. So while it's something to monitor, I don't think it's something that's necessarily going to defeat the trial before it starts. So people are saying that this may still be a viable approach to treating people with mild symptoms due to Alzheimer's disease. For patients who are symptomatic, BAN 2401 might be offered to them, with all the caveats that in fact many of the other trials going at the same patient population have failed. What are the risks? What are the benefits? And let the patient and family decide as to whether they want to enter into the trial. So gantenerumab is another antibody that is designed to remove the aggregated forms of amyloid from the brain. Now, it's gone through several early trials and they were ineffective, but perhaps the dose was inappropriate. So what the individuals doing these trials have done is increase the dose of gantenerumab, and I think it does in fact remove amyloid from the brain, like several of the other antibodies. But the key question is there going to be a clinical accompaniment to that? Are people going to stabilize, maybe get better, but at least stabilize clinically? Some of the recent disappointment in the field of Alzheimer's therapeutics has arisen from the failure of the 2 aducanumab trials. Now, these trials were designed again to remove the aggregated form of amyloid from the brain, and the preliminary data from a study 3-4 years ago indicated that the antibody was in fact quite effective at doing what it was supposed to do, that is, removing amyloid from the brain. So if you do serial PET scans on people, you can see the amyloid being taken out of the brain, and the actual total amount is reduced as you go further into the trial. Now, the million-dollar question has been, does it make any difference clinically for these individuals? So, unfortunately, just recently, the Data Safety Monitoring Committee for this study did a futility analysis, meaning that they assessed the likelihood that, looking at the data at this point in time, is there any way the trial could be positive, carried out to its full extent? And they came to the conclusion that apparently not, that we should stop the study at this time, not risk patient safety any longer. The study is not going to be positive. Now, they looked at one aspect of the data, which are very important, and they probably came to a reasonable conclusion. But the supporters, the sponsors of this study, need to drill down into the database and look at it much more carefully to see if there are any signals, because while we say these trials fail, we learn a great deal from them that may inform us about designing the next trial. The class of drugs called BACE inhibitors has been investigated rather aggressively in the last year or so. And at a recent meeting in Europe in the end of 2018, 3 of the drugs by different companies reported failures to do what they were supposed to do on the one hand, and actually may have had some side effects that were bothersome. Cognitive worsening, maybe some psychiatric symptoms were appearing. So all 3 of these trials were halted in that class of BACE inhibitors. Now, there are still a couple left, and L-Basistat is one of them, and it has been monitored closely now for also these side effects. And at this point, it appears that this particular compound is not producing those side effects. Now, whether it's producing any benefit is a whole other issue. But L-Basistat is one of the BACE inhibitors that is going forward now in some of the newly designed trials. The FDA, I think, is very primed to approve a drug for Alzheimer's disease if, in fact, it can be shown to be efficacious. So I think the FDA will fast-track a variety of drugs which will move the process of approval through much more rapidly. Then we'll follow the drugs carefully post-approval to make sure there are not problems with them. But I think the FDA is a partner in trying to develop effective therapies for Alzheimer's disease.